Welcome to PGOG postgraduate class in obstetrics and gynecology, and today's topic is pelvic organ prolapse, an overview of management. Non-surgical treatment options for the pelvic organ prolapse are, you should remember these four, that is lifestyle modifications to correct the modifiable risk factors such as weight reduction for obesity, cessation of smoking if chronic cough is a risk factor for exacerbation of the prolapse, and treatment of constipation. Supervised pelvic floor muscle training (PFMT) is important non-surgical treatment option for which should be done for at least 16 weeks, and it is supervised by a physiotherapist, trained physiotherapist in that area, and it is specially indicated for stage 1 or stage 2 by OPQ quantification system of the pelvic organ collapse. Stage 1 is when the descent of the leading part is above the 1 centimeter above the level of the hymen, whereas stage 2 is it is plus minus 1 centimeter of the hymen, considering hymen as the 0 point, or it is considered as the reference point that we have already seen. And for those who have not gone through the previous videos, please first go to the previous videos so that you will understand the concepts which we are discussing in present video. Previous videos related to pelvic organ prolapse are 4. This is the 5th one. Third, non-surgical treatment option is the use of vaginal estrogen for postmenopausal women who have vaginal atrophy, and vaginal ring pessary also it is the important non-surgical option. Now there are many pessaries. If you go through the textbook, there is a picture which shows so many different sizes of pessaries are there. But the one which is most commonly used is ring pessary. This is only problem is if there is a widened introitus, then there can be a spontaneous expulsion of this, and in that case you might have to use other types of pessaries. Otherwise, commonly used pessary is ring pessary. It is made up of PVC or silicone. We need to fit the correct size, and that is why sometimes we may need to try different sizes. So we try for one, and if there is an expulsion, we try a bigger one. If there is a pain or any other difficulty, we try a smaller one, like that. It needs to be removed and replaced every 3 to 6 months. It can be done by patient. If we can train the patient, then it can be done. This removal and replacement can be done by the patient at home, but she needs to come for a annual checkup. One checkup in a year is mandatory. If a patient is an old woman and there is atrophic vagina, then prior estrogen vaginal cream is to be given for 2 to 3 months, and then we can try this use of ring pessary in that patient. What is the placement technique of ring pessary in pelvic organ prolapse? You first fold this pessary and then insert inside so that it doesn't lead to any pain, and use lubricant so that the insertion of the pessary is not painful. Then you place it antero-posteriorly and see to it that it goes above the level of pubic symphysis so that there is no compression at the uretrovesical angle or junction. Now it should be at least 1 centimeter above the introitus when the patient is straining maximally. That means that you have inserted it in the correct manner. Also, sweep your finger all around to confirm that there is no entrapment of bowel in it. Then let the patient sit, walk and pass urine, and then only you send her home once you fit the pessary. How it works? It stretches the vagina. Indications, if you are asked, that is a commonly asked question in your practical examination also, because ring pessary is usually kept for the table viva. So what are the indications for the use of pessary in pelvic organ prolapse? Ideally, it should be tried, and pessary trial needs to be given to every patient before you take a decision for a surgery. So that if patient uh, is becomes symptom free and patient can continue to use it properly, it can be even used for a long duration also. Surgery for the pelvic organ prolapse should never be the first line of treatment because it is associated with so many complications, and we should remember that as such prolapse is not life threatening condition. It is leading to morbidity only, but some of the complications can lead to can be life threatening also, and that is the reason we need to take a decision for surgery carefully. And for this reason only, pessary trial is indicated for all the patients who are uh, in whom you might consider in future to proceed with surgical management. If it is a symptomatic pelvic organ prolapse and patient wants pregnancy in future, then for this situation, pessary treatment is ideal. Now there are so many surgeries where we can do the uterine preservation, and all these surgeries are usually called as hysteropexies or sling operations where we do the cervicopexy. Now these surgeries, these are to be considered as second line of treatment whenever patient wants to have pregnancy in future. The reason is pregnancy will weaken this hysteropexy and it will increase the risk of recurrence of pelvic organ prolapse with need for a repeat surgery. And that is the reason first line of treatment whenever symptomatic of prolapse is there, but patient wants to conceive in future, it has to be ring pessary. When a patient comes with pregnancy and she has prolapse, then for initial first half of the pregnancy, pessary needs to be used, and once the uterus is lifted up above the pubic symphysis from 18, after 18 weeks, usually the prolapse by itself reduces. So up to first 18 weeks, we need to use pessary in pregnancy. In puerperium also, pessary needs to be used in these women who have conceived with pelvic organ prolapse. Then it is used to treat the decubitus ulcer. All of you must have seen that in long-standing cases of prolapse, what you find is there is a ulceration at the or just by the side of the external os. The cause, and this is called as decubitus ulcer. The cause of decubitus ulcer is not usually infection. So sometimes it might get infected secondarily with the exposure outside. But main cause of the decubitus ulcer is, that is also commonly asked question, what is the cause of development of decubitus ulcer? Or it is because of the venous congestion. The venous return from this tissue is hampered because of the uh, tissues which are at a abnormal position at a lower position than normal. That leads to the excessive venous congestion, and that is why there is a formation of these ulcers. So the treatment of these ulcers is to keep the cervix as well as to keep the vagina in its own original position. That will reduce the congestion and that will lead to healing of the ulcer. Non-healing decubitus ulcer is an indication to take a smear and rule out malignancy, but usually it heals with the uh, restoration of anatomy and with the estrogen vaginal creams. And if required, antimicrobial creams are also can be tried. So pessary, if we insert the pessary, patient can go home rather than doing the vaginal packing on daily basis and hospitalizing the patient for the decubitus ulcer healing, because unless the ulcer heals, we can't take the patient for surgery. And just for that pre-operative preparation of the patient also, pessary treatment plays an important role. Whenever a woman is unfit for surgery, then also we need to try uh, use of pessary. Whenever we use the pessary, we should be aware of the likely complications because of the what complications can occur because of the use of the ring pessary. Now, if the pessary is kept and it is not changed as it should be, ideally it should be changed on a once a week basis by the patient at home, and at least every 3 months it needs to be replaced. 3 to 6 months it needs to be replaced also. And if all these precautions are not taken, it leads to formation of a vaginal erosion. So vaginal erosion will lead to excessive vaginal discharge, pain, in pelvic pain can be there, and even sometimes bleeding also can be there. This, if the patient comes with a vaginal erosion, especially it will be more common in the atrophic vagina in elderly women. Treatment is we remove the pessary for 2 to 4 weeks, apply estrogen vaginal cream, and antimicrobials also are to be given if it shows features of infection. Pessary expulsion can occur especially whenever there is an introital widening in a patient of pelvic organ prolapse. Pessary can lead to urinary retention if it is compressing at the urethrovesical angle. In a forgotten pessary, fistulas can occur. There can be vesicovaginal fistula or rectovaginal fistula, and it will be more commonly seen with the atrophic vagina. Now, coming to surgical management. First, we have seen the lifestyle modifications and all the non-surgical approaches to the management of pelvic organ prolapse. But if all this patient is not willing for either ring pessary or there is a failure of ring pessary and we need patient is symptomatic, then in that case we need to take a decision for the to proceed with the surgical options. There are so many surgical options, and that is why to remember which surgery will be needs to be decided for a particular patient, we need to understand these surgical options, and it is easier to remember compartment wise. And all these compartment wise surgeries I have already covered in separate videos which are available in the playlist of pelvic organ prolapse. Except colpocliasis, rest of all these surgeries we have seen in the previous videos in detail. So anterior compartment defect, what is done is anterior colporrhaphy. Posterior compartment defect, what is done is a colporrhaphy with or without perineuraphy. If there is a damage to perineal body or membrane, then we have to do perineuraphy also. Third compartment is central or apical compartment, and maximum surgical options are present related to this compartment, apical compartment. And the apical compartment defect is not taking proper care of apical compartment defect is the commonest cause of recurrence of pelvic organ prolapse after surgery. And that is the reason this apical compartment defect repair is of most importance whenever we operate on a case of pelvic organ prolapse. It depends on apical support surgeries. It depends on whether uterus is being removed or preserved. So we can divide after the surgeries as surgeries where uterine preservation is done and surgeries where hysterectomy is done, and then along with hysterectomy, apical support surgery has been done. And third group is ward prolapse, where there is a prolapse after hysterectomy. Now, whenever a woman is surgically unfit, old and sexually inactive, then colpocliasis is the procedure of choice for such women. Apical support surgeries, a complete video is available only dedicated to these apical support surgeries. In short, uterine preservation surgeries we can divide in vaginal and abdominal. In vaginal, either we attach the uterus to uterosacral ligament, that is uterosacral hysteropexy, or to sacrospinous ligament, that is sacrospinous hysteropexy, or we can do Manchester or Fothergill's operation. This I have not covered in the previous video, that we will see in detail in today's video. Abdominally, uterine preservation surgeries can be done laparoscopically or as open surgeries. Here the most popular is sacrohysteropexy, where the uterus is attached to anterior sacral ligament just below the sacral promontory, or various sling operations which are also called as cervicopexy, where we are attaching the slings or tissues to the cervix, either anteriorly or posteriorly. Now, when hysterectomy is done, in that case, apical support surgery is to be done as additional procedure after removal of uterus. So, for that, either we can do mechanical scaldoplasty, uterosacral ligament suspension, sacrospinous ligament fixation, or sacrocolpopexy. I hope that by this time you must have gone through the previous videos so that you understand what these terminologies mean. Now in vault prolapse, again we can do uterosacral ligament suspension either abdominally or vaginally. Sacrospinous fixation also can be done abdominally or vaginally, or we can do sacrocolpopexy. The most popular procedure for vault prolapse at present is laparoscopic sacrocolpopexy, which is done abdominally. It can also be done as open procedure or with the help of laparoscope. So in previous videos, we have seen the surgeries for anterior compartment, posterior compartment and apical compartment. But this Fothergill's or Manchester's operation I had not covered in the previous video, and that is why we will see in little bit detail about it. Now this is a procedure of choice whenever there is a cervical elongation and patient wants uterine preservation. Step is dilatation and cavitation is done so that post-operatively there is no micrometra or pyometra. Cervix remains dilated. Step 2 is we do cervical partial amputation. Step 3 is plicating the cardinal ligaments on the anterior cervix. So this plicating will lead to the shortening and strengthening of cardinal ligaments or McIntosh ligaments. Step 4 is anterior and posterior colporrhaphy with or without perineorrhaphy as per the need in a particular patient. If there is a cystocele, we do anterior colporrhaphy. If there is a rectocele, we do posterior colporrhaphy. And if there is a damage to the perineal body, we will be doing perineorrhaphy. This is what is diagrammatically. Step 1 is dilatation. This is a commonly asked question in practical examination, remember, because so many examiners have already done this surgery many times in their career, and that is why it is a relatively a favorite question. So that now if you see the younger gynecologists, they might not be opting for this operation. Even Tillian's operative gynecology is not mentioning Manchester or Fothergill's operation because now better options such as abdominal sacrocolpopexy, abdominal sacrohysteropexy are more popular than these operations because this was associated with failure and recurrence of prolapse in many cases. But still, you should know because this is still being done at some places in the world. Step 1 is dilatation and curettage. Step 2 is partial amputation of the cervix where the cervical amputation is done, this red area. Then you bring the cardinal ligaments and suture them on the front of the cervix, that is plication of cardinal ligament is step 3. And step 4 is as per the need of the case, anterior posterior repair has to be done. Now, if we see the focus or FOXY guideline 2021, it mentions about the sling operations for pelvic organ prolapse, especially in young women, where there can be either a nulliparous prolapse or congenital prolapse, or patient can present in. It is common in India that in 20s only we get patients who had a previous difficult vaginal delivery, and patient is so young who is keen to conceive in future, but she has already a stage 3 uh, pelvic organ prolapse. So in these women, what is important is to provide a apical support. And for that, these sling surgeries are done, which is other name for that is cervicopexy, because we are anchoring the cervix to various tissues. Purandar sling was the most popular one, which was done for nulliparous prolapse and when there was no rectocele. What was done was rectus sheath strips were anchored to the anterior cervix. That was the native tissue used, which was done in original Purandare. But nowadays, with better availability of the non-absorbable Marcelin tapes are being used for the same purpose. One end is attached to the anterior cervix and other end is attached to the rectus sheath. Hanna sling is another one where the tape is attached to anterior superior iliac spine and other end is attached to anteriorly to the cervix. Shirodkar sling is where uh, tape passes from posterior cervix to the anterior sacral ligament or sacrum, and here when it is right it can pass retroperitoneally, but on the left side we need to make a psoas loop, so that technically it is more difficult. We have to make a psoas loop, and this sling has to pass through that psoas loop retroperitoneally to reach to the sacrum. Virkud sling is a modification of this, so that right side we do as Shirodkar, where the this tape is attached to posterior surface cervix and to the anterior sacral ligament. But on left side it is done as Purandare. That means the sling is attached to posterior cervix, but other end is attached to rectus sheath. So we can say it is like a combination of Shirodkars and Purandares to get away with the technical difficulty with the Shirodkars, so that this combination has been introduced by Dr. Virkud. Sunawala's is where only Shirodkar on right side is done, left sided making of psoas sling, muscle sling loop. Psoas muscle loop is not done. So it is only one sided, which might lead to the tilting of the uterus to one side. Zoshi's sling is where the anteriorly the cervix is the tape is anchored to anterior cervix and other end to the pectineal ligaments, and you approach these pectineal ligaments through retropubic space, and it is done on both the sides. Now coming to colpocliasis, which was also not covered in the previous classes, and I am also, that is why I am discussing somewhat in detail about these remaining procedures. So it is Leafold's colpocliasis is commonly done. What is done in short here is anterior rectangular vaginal flap is removed, which is from bladder neck at the superior end to the 2 centimeters away from the external os at the inferior end. So we can see here this such as a rectangular flap is excised. Only vaginal epithelium or vaginal mucosa is removed, and a symmetrical flap is removed from the posterior vaginal wall, and then with serial sutures vagina is obliterated with the lateral margins remaining open for the uh, discharge, drainage of the cervical and vaginal discharge. So here partial obliteration of the vagina is being done, and that is why colpopiosis is one of the obliterative surgeries. Now, if patient, now it is rare to have only enterosil, and usually enterosil repair is done in combination with all the other procedures when we are doing vaginal hysterectomy and we are doing anterior and posterior repair. Along with that, Mackel scaldoplasty is done after hysterectomy, which takes care of enterosil. It prevents the formation of enterosil post hysterectomy. So Mackel scaldoplasty is mainly we are repairing the cul-de-sac, and that is how we take care of the enterosil repair, which you can go through the previous video for the details. Abdominally, there are some procedures which have been described for the taking care of the enterosil, where the procedure is called as either Halban's or Moshkovi's procedure. What is done in that is first string sutures are taken at the pouch of Douglas over the uterosacral ligament and in between the peritoneum, taking care not to injure the ureter or not to include the ureter, and that is how this pouch of Douglas is closed with the successive first string sutures. Now, if we see the guidelines, if we see NICE 2019 guideline, what is it? It is recommending only few surgeries. We have seen so many options till now. What they are suggesting is when patient is willing for hysterectomy, then to go ahead with vaginal hysterectomy, with or without sacrospinous fixation with sutures. Now with sutures is that means they do not want the mesh to be used. That is clear. And even sacrospinous fixation is not mandatory in each patient. If apical defect is there, then we need to go for sacrospinous fixation after vaginal stitching. Vaginal sacrospinous hysteropexy when patient wants preservation of uterus with sutures. Manchester or Fothergill's operation is mentioned in that NICE guideline, which has not been mentioned, as I said, in Thielend's operative gynecology. Sacrohysteropexy, that is joining the or providing support to the uterus with the attachment of the tape to the mesh to the anterior sacral ligament with mesh. It can be done laparoscopically or it can be done as an open procedure. And colpopliasis as obliterative surgery for surgically unfit, old and sexually inactive women. So only these procedures have been mentioned, and you can see here sacrospinous fixation they are promoting more as compared to either macrospaldoplasty or vaginally to do the uterosacral ligament suspension. Rather than that, they are preferring sacrospinous ligament fixation is important point I want you to appreciate. What is our Indian guideline says is for uterine preservation surgeries, all the sling operations are described. Now in India, these are all the sling operations or cervicopexies. These have been introduced by all the Indian surgeons, and the main reason is we get so many women who are coming to us in young age, either as nulliparous or congenital prolapse, or we have women only with one vaginal delivery coming to us with the cervical elongation and coming to us with a full-blown anterior posterior compartment defect as well as apical compartment defect is a major problem. And that is the reason so many various techniques have been introduced by Indian surgeons, and that is the reason these sling operations are not being mentioned in these textbooks written by foreign authors such as Thielend's operative gynecology, or even in their guideline you won't get in NICE guideline, but this is an integral part in the Indian guideline. Other uterine preservation surgeries have also been described by Foxy, such as Manchester operation where there is a cervical elongation, sacrospinous hysteropexy, or uterosacral ligament suspension. These have also been mentioned along with sling operations. Now, what Foxy says is primary prevention is reducing the use of forceps. That will lead to reduction in obstetric trauma, mainly responsible for this development of pelvic organ prolapse. And secondary prevention is post-delivery. We need to advise the patient for pelvic floor muscle training. That is important prevention. Yeah, post-delivery pelvic floor muscle training, which will reduce the incidence of or prevalence of prolapse in our setup. So what is not being mentioned in Thielend's operative gynecology is sling operations and Manchester or Fothergill's operation. In nutshell, if you will see, or at the end, so many names of the surgeries we have and how to remember. So first is obliterative or reconstructive surgeries for pelvic organ prolapse. Obliterative only one, colpopliasis, as you can see here, the partial this colpopliasis is in the center. We have are obliterating the vagina, whereas laterally the drainage lines are still patent. The reconstructive surgeries depend on which compartment defect patient has. Anterior compartment, we go ahead with anterior colporrhaphy. Posterior compartment defect, we go with posterior colporrhaphy with or without perineorrhaphy. Perineorrhaphy will increase the length of perineal body. If there is an intrusive repair, usually it is associated with other defects, so that I have put it in the center that we need to do it. Remember that we need to identify, we need to correct the intrusive, and we need to prevent the intrusive if we do hysterectomy. So if we do the hysterectomy, we need to remember that medical scaldoplasty takes care of intrusive. And if abdominal surgery is being done, then we can do the Halban's or Moscow's surgery for the obliteration of the pouch of Douglas with the 4-string sutures. Now, if there is a apical defect, which is the commonest defect, is anterior. If you are asked which is the commonest compartment defect, it is the anterior compartment. But which is the one which is missed while we see a patient, or which remains uncorrected maximally, it is the apical compartment, and that is why we need to focus on apical compartment. And usually in majority of the women, whenever there is a pelvic organ prolapse, apical compartment defect repair needs to be added to whatever surgery we decide to proceed with. Now, if patient has uterus, there are some surgeries, and if there is post-hysterectomy cases there, then we call it as a walled prolapse. So with uterus, either we can go ahead with vaginal hysterectomy with McCall's scaldoplasty as a procedure for apical compartment defect repair, or any one of these three we can proceed with that. After doing a vaginal hysterectomy, either we can do sacrocolpopexy, or we can do even abdominal hysterectomy and sacrocolpopexy can be done. We can do SSAP, sacrospinous ligament fixation, or we can do uterosacral ligament suspension. So any of these can be combined whenever we are doing a hysterectomy. Now, if there is a cervical elongation and patient wants preservation of surgery, we can go ahead with Manchester or Fothergill's, where partial amputation of the cervix is done. For uterine preservation, we can go for hysteropexy, various types of hysteropexy such as sacrohysteropexy, or sacrospinous hysteropexy, or sacrohysteropexy. Sacrospinous is attaching to the sacrospinous ligament, uterus or lower end of the uterus, that is cervix and vagina. Sacrohysteropexy is attaching the same with the anterior sacral ligament. So that is the difference in these two, sacropexy and sacrospinous fixation, or sacrospinous hysteropexy, or we can even do uterosacral hysteropexy. And all the various types of slings which we have just now seen, so many slings we have now. These are cervicopexies, which can also be done whenever the patient wants a uterine preservation. So uterine preservation, either Manchester or Fothergill's, or slings, or hysteropexies. Vaginal hysterectomy, we need to add the apical support surgeries, McCall's, or any one of these three. If it is a walled prolapse, patient had hysterectomy in the past, abdominal or vaginal, and she is coming with the walled prolapse, then either we can go with for sacrocolpopexy, which is usually done with the abdominally, either with a laparoscope or open surgery, or this walled suspension can be done as a sacrospinous ligament fixation or uterosacral uh, ligament suspension. So this is in short about the various surgeries. Remember that first you start with obliterative and reconstructive, then you see which is the compartment which is being affected. But for apical, there are so many options, and here we need to divide in whether a uterus is present or whether it is post-hysterectomy case, whether patient wants uterine preservation or patient we can proceed with the hysterectomy. Depending on that, so many options are available, and ultimately the choice of surgery, as we have already seen in the previous video, it depends on surgeon's expertise as well as patient's goal. Which symptoms patient is worried about, and what is her expectation from the surgery, along with the surgeon's expertise. That will decide which procedure to be selected for a particular case. Thank you so much.